Professor Kaiwen Huang from Taiwan and me, Dr. Letterman from American School. So for the first speaker, I would like to introduce Professor Kaiwen Huang for the first topic. So his talk today will be the orchestra of local operation and immunotherapy. So Professor Huang is now work at the Center of Mini Invasive International Oncology, the National Taiwan University Hospital. He's also the chair of Taiwan Academy of Mini Invasive Intervention and the chair of Asian Ocean Chapter of Society of International Oncology. So Professor Huang, please.
Thank you for the kind introduction, and I also to thank you for your attention to this joint session. I'm joined by the VSIR and SIO, and thank you on behalf of the Society of International Oncology. Today I would like to share the experience to introduce the current trend of the orchestra, the cooperation between the local regional therapy and the immunotherapy for HCC and this topic, and why accepted and why introduced in these years. This is a small study in my hospital. We do IFA for the animal model. You can find over the back of these mice, there are two tumors, left and right, two tumors. And the two tumors are HCC. And we do IFA for one of these tumors. And then we do anti-PD-L1 immunotherapy for this animal. We can find in the control group for the upper side tumor, the untreated tumor, the progression disease is certain. And for the tumor receive one of the tumors of operation, you can find it cannot stop the progression of the other tumors. When we perform the anti-PD-L1 inhibitor, and we can find some tumor was reduced in size. However, when we combine the local operation for one tumor and we observe the second tumor, and we can find some tumor, two animals show complete response for the other tumors. It means the combination of local regional treatment and the immunotherapy is possible. Therefore, you can see the size is reducing size very much. Then we can find the outcome is long-lasting. After 7 days, you can still see the tumor, untreated tumor, actually the size is stable. And we also can find the CD8 T cell and the NK T cell and the NKT cell. We can find the number increase after combination therapy. So now we know the result of liver cancer treatment is related to the immune mechanism. The something follow the local regional therapy, we can find the infiltration of immune effector, especially the CD8 positive infiltration will increase, and that will decrease the recurrence. NKT in the beta gamma are also very important markers. However, the accumulation of immunosuppressive cells, including Treg, MDSC, and some macrophage, will inhibit the anti-tumor immunity and result to a bad outcome. However, we could not overcome that by the immunotherapy. So now, we knew after the curative tumor operation, we could see the interferon gamma level to differentiate the good outcome and the bad outcome. You can find the interferon gamma level in serum actually is a very important factor about the outcome. The higher, the better, the lower, the poor. As for the patient receive RFA treatment, and the tumor-associated antigen-specific T cell response is very important. The study was published 10 years ago in the pathology. They collected 69 patients, and within the 11 TAA derived peptide was evaluated. And they found the TAA-specific T cell increased in 60% of patients. And the TAA-specific T cell after the IFA is very important. If the TAA-specific T cell increase and the recurrence rate will decrease, and then we can see the outcome will be better. Not only for IFA, but also microwave. In this microwave study, we can find microwave will enhance the TAA response. And the TAA-specific T cell inverse correlated to HCC recurrence. It means the same outcome when we perform the microwave operation. If we separate the patient between the two groups, one with a higher TAA, one with a lower TAA, you can find the outcome. The survival is totally different. The newest device, maybe is IRE, irreversible electroporation. It shows the same result. We can find the patient when we treat the IRE for the patient's tumor, especially for the HCC or the pancreatic cancer or the cholangiocarcinoma. We can find the CD8 positive T cell will increase. We can find the number will be increased. Not only CD8 but also CD11C. You can find the result is long lasting. And not only for the CD8 cytotoxic T cell, but also for the Treg and the PD-1 inhibitor. You can find the fast P3 and the PD-1 will decrease after IRE treatment. It means we could use this item, we can use this factor to cooperate with immunotherapy. Maybe we can get a better outcome after for original treatment, including IFA, microwave, and IRE. The rationale is that when we perform the tumor treatment, we can find this is the normal tumor. It is a so-called non-inflamed tumor. In HCC or cholangiocarcinoma and pancreatic cancer, this kind of tumor was called cold tumor. Very, very limited inflammatory cell within it. So even we do immunotherapy, the result is not so good. However, when we perform local regional therapy, including TSE or IFA, we could destroy the tumor and we could release the antigen. We could increase the cytokine, increase the angiogenesis, increase the HIF-1 alpha hypoxic effect. And then this induced the fact that will attract the dendritic cell, will attract the T lymphocyte as the infiltrating tumor infiltrating cell, and induce stronger immune response. At that time, when we give the checkpoint inhibitor and the vascular targeted anti-angiogenic drug, we will increase the effect. This is quite good because the checkpoint inhibitor and the anti-angiogenic factor are now accepted as the first or second line treatment of HCC officially. So we can find when we try to do the TSE or IFA, then we will use this benzaldesleukin or sorafenib and latinib regrow is anti-angiogenesis. We will use also anti-PD-1, PD-L1, or anti-CTLA4 antibody as an adjuvant treatment. And now we have already 10 systemic therapy available for HCC since 2007, and some of them are TKI, molecular cytotherapy, and some of them are immunotherapy. We can find not only for the second line treatment, including the pembrolizumab, nivolumab, and pomalidomide, plus the ipilimumab. There are also the first line treatment, tenofovir, the durvalumab, and these treatments now are available in many countries in Asia Pacific area. This is an example in Taiwan. The patient is a 69 years old male HPV carrier. He used to be treated by a ribopectomy, and the liver function is good. Alpha liver protein over 3,000, and we can find there are multiple liver recurrence with the BCLC B stage. And then we do TSE combined with IFA. And 3 months later, we can find the new lesion over here. So we do it again, twice. After that, there are new lesions over the different part of the mountain. Compared with the previous image, you can find the lesion was newly developed. It means TSE refractory now. So we have to change our policy. So we start to use tenofovir, this is the first line immunotherapy and anti-angiogenic therapy. For 4 cycles, we can find the tumor was subside. It's only 3 to 4 months. And alpha liver protein from more than 9,000 to 120 to 12, nearly complete remission. It means we have to change our principle. We combine the immunotherapy for this patient with the TSE or IFA refractory. So immunotherapy after local regional therapy could be earlier used after the failure was confirmed. The result was proven by the IMBRANCE 150 this trial. This trial is very important. concept to tell us when we do local regional therapy, if it fail or refractory, or we want to increase the result, we could add on the immunotherapy. This study divided to the Tezobeva and the sorafenib group. And in these patients, they enrolled around half prior received the local regional therapy. And some of them are IFA, mostly are TSE. For this patient, we can find the result actually is quite good, especially for immunotherapy. This is overall survival and around 22%, and the surrounding is 10%. What's more important is you can find when the patient receives 1 to 2 times of local regional therapy, at the time we do the immunotherapy and we can result in the best result. If we do more than 3 times local regional therapy, the result will become poorer. Not only in the overall survival, but also in the progression-free survival, we can see the result will become poorer. It means we have to shift to immunotherapy earlier when we found local regional treatment is useless. So this is a short conclusion. The survivability was proven in this clinical trial. So now, Tezobeva became one of very important first-line HCC treatment. And for the local regional treatment, the more benefit will be archived in 1 to 2 times the local regional treatment. So we have to switch into the local regional treatment earlier. And the safety and the probability profile actually is good for this BCLCP patient. And for this combination now has already been well accepted and encouraged in the guideline and the consensus. So not only for the immunotherapy after local regional therapy, we also could use the immunotherapy before local regional treatment. This concept is conversion therapy. Before we do local regional therapy again and again, DSC, IFA, and for lots of local regional therapy, then we found it failure. At the time, we did systemic therapy. But now the new concept is we give the immunotherapy firstly. If the patient could result in marked tumor shrinkage, we could do resection, IFA, DSC for this patient with the intention to treat to cancer-free with drug-free. This study was organized by Dr. Kudo recently. They enrolled 110 patients to receive Tezobeva immunotherapy. And then, when conversion was noted, they do local regional treatment, including resection, ablation, microwave, IFA test. And totally, 38 patients result in complete remission. It's around 35%. And the result is quite good. If the patient could induce complete remission after resection, the outcome is very, very good compared with the patient cannot achieve the complete remission. The patient has lots of tumor within the right lobe, and he received a Tezobeva treatment. You can find the tumor was decreasing in size. However, very strong side effect was noted. But outcome is good. You can see the tumor marker almost normal. And we can see the tumor is still viable, this one, under the contrast ultrasound. So we do IFA for this tumor. And we ablate the tumor totally, and we can stop the drug, become cancer-free and the drug-free. This is the auditory, the symphony, the combination of immunotherapy and local treatment. So there another useful method of immunotherapy after local regional therapy is the adjuvant therapy. Is a very new concept. Just completed the clinical trial recently, and the main target is HCC. Why we have to focus on early HCC? You mean even we perform the best treatment, surgical resection, for a patient with early HCC, you can find a response and the outcome is poorer and poorer through the follow-up. Because the early recurrence, late recurrence, and metastasis actually is very common, even for early HCC. So recently, there are lots of combination clinical trial with immunocheckpoint inhibitor and regional treatment or radical treatment. You can find there are lots of adjuvant for monotherapy, adjuvant for combination, even for early HCC. And the local regional therapy combined with ICI has already erased the indifference series of test result. You can find this patient he received the TSE, then he received the training treatment. We can find for 8 weeks, 6 months, and 40 months, more than 1 year, the tumor is almost stopped in growth. And this patient is also received the IFA, and then he keep the treatment, immunotherapy. The subtotal IFA and combined with the immunotherapy for 24 weeks, and the situation is very, very stable. So recently we achieved the brain 050 study combination with the local operation, immunization, and the immunotherapy. The targeted agent is atezolizumab, and in high-risk patient. What is the high-risk HCC? For recession, the bigger tumor, bigger than 5 cm in diameter, multiple tumor, or vascular invasion, poor differentiation. As for IFA, the bigger tumor, between the 2 to 5 cm, or multiple tumor around 2 to 4 tumors. And for this high-risk patient, we will consider to give the atezolizumab or just observe. And the result we can find, just published recently, and the median follow-up is 17 months, and the progression-free survival was improved dramatically. The progression-free survival is from 78% compared with the 65%. The result is significant. As for the AE, we can know if we don't do any combined treatment and just only follow it, there's almost no significant complication. However, when we add on the atezolizumab, we can find the complication rate, the AE will increase. However, mostly are very, very low grade 1 to grade 2 AE, and this side effect actually is very similar with the patient with less stage to be treated by atezolizumab. As for the high grade AE, actually still uncommon, except the proteinuria, hypertension, and the thrombocytopenia. Actually, this AE is quite easy to be controlled by medical treatment. And not only for the atezolizumab, but also for the nivolumab and the PD-1, you can find for the treatment, the 1 year, 2 year, 3 year recurrence-free survival after the adjuvant treatment for the high-risk patient, 76, 58, and 46 actually is quite good. However, in study, we also found there are so-called biomarker. The Treg infiltration and the beta-catenin activation will prevent, we will use this for the nivolumab arm. It means in the future we could consider to find out the biomarker to pick up what kind of patient is suitable for add-on immunotherapy. So this is a small conclusion for today's introduction. The global guideline clearly identified the definition of local regional treatment on suitable patient, and the benefit of upfront systemic therapy was known now. Immunomicroenvironment play important role in tumor recurrence, and the local regional therapy may modulate the microenvironment and has the potential to increase the survival period. Immunotherapy may have any chance to induce tumor downstaging and the conversion to curative therapy. According to the current serious and clinical experience, we found mostly are local regional treatment, not recession, as mostly are local operation. So it means there will be more and more opportunity for the doctor who perform local operation in interventional oncologist to cooperate with oncology. And the concurrent therapy could effectively treat the advanced HCC through sustained local tumor necrosis, and could effect systemic control for patients who receive curative intent. The efficacy of immunotherapy is still under investigation, especially for the patient treated by TSE, IFA, microwave, IRE. We are waiting for the result of ongoing achievement trial, and we intend to evaluate more and more this kind of trial by ECTA or the SIO. And then it introduced the Asia Oceania chapter of the Society of Interventional Oncology. It's a branch of SIO. It's SIO in Asia. And you're welcome to join SIO. And it's through the Asia Oceania chapter, same membership at extremely low fee, around 1/10 only. And more and more international cooperation in this group is the platform for training and education. And if you are in a society and have the necessity to come join with SIO or ECTA, just informed us. This is the current leadership of the me, Dr. Huawei and Dr. Kim networking. And this is the speech. Thank you for attention.
Thank you, Dr. Huang, for that excellent presentation with very updated and in-depth knowledge.